Hello, everyone. My name is Satish Gadi. I'm an interventional cardiologist at Cardiovascular Institute of the South. I would like to thank Dr. Walker and the NCVH team for this incredible opportunity to do the NCVH Digital Education Series during these very challenging times. My topic for today is what is the current status and future role of PCSK9 inhibitors? No pertinent disclosures to this topic, but the rest of the disclosures are there. Let me jump right in. Essentially, in terms of dyslipidemia and anti-lipidemic therapies, we've all known for a long time that reducing LDL directly translates into reduced cardiovascular event rates. We know this from several decades, really, of statin data, both in the primary prevention and the secondary prevention realms. And we know this from multiple landmark statin trials across several different varieties of statins. However, we do also recognize now more than ever that we do need to look beyond just statins. Statins are nevertheless the sort of backbone of anti-lipidemic therapy, but what is really stunning, especially to me when I came across this piece of statistic, is that almost 70% of people in the United States with established known cardiovascular disease are still not at goal in terms of their LDL cholesterol, despite being on statins and or ezetimibe. So obviously there is a vast amount of work to be done in terms of reducing LDL cholesterol and in terms of reducing cardiovascular events. One of the other questions that I would like to touch upon is essentially how low can you go in terms of cholesterol? We do know that high intensity statins do much better than moderate intensity statins in terms of preventing cardiovascular events, especially in the secondary prevention realm. And also, we also know that really there's no floor as such for LDL cholesterol. You could go as low as you can possibly achieve. There are many therapeutic options to choose from. Statins obviously are HMG-CoA reductase inhibitors which is an essentially rate-limiting step in cholesterol synthesis. But also now, the new kid on the block, which is PCSK9 inhibitors, which is the scope of our discussion today, they essentially inhibit the PCSK9 protein. And just a little while later, we'll talk about the exact mechanism of action. There is another upcoming molecule that we're all interested in as well, the drug that inhibits the PCSK9 mRNA, inclisiran, but that's something that is investigational at this point. Again, a lot of different studies over several decades have laid the foundation of current present-day anti-lipidemic therapy. In fact, LDL reduction and anti-lipidemic therapy probably is one of the most heavily investigated topics in the field of medicine. So getting back into the nitty-gritties of PCSK9, PCSK9, short for proprotein convertase subtilisin kexin type 9. This is a protein, and I have no idea why they come up with such hard names, but this is a protein that actually chaperones the LDL receptors to destruction. So the way it works is LDL binds to the receptor, the whole complex is internalized, PCSK9 molecule then grabs the LDL receptors and destroys it, preventing the LDL receptor from recycling back to the surface to grab more LDL particles. So obviously, if there was a gain of function mutation, there would be more PCSK9, greater destruction of LDL receptors. So there are fewer receptors available to clear plasma LDL. And also the other way around, which is loss of function mutants, where there is more LDL receptors available to gather more LDL cholesterol, thereby reduce LDL cholesterol levels and reduce the risk of MI. So we've seen both gain of function and loss of function genetic variants. And essentially, by discovery of those genetic variants is how we hit upon this PCSK9 molecule, its importance in LDL metabolism, and then that became a potential therapeutic target. The two available FDA-approved PCSK9 inhibitors in the market currently, evolocumab and alirocumab, are both humanized monoclonal antibodies that bind to the PCSK9 protein and prevent it from destroying the LDL receptor. They achieve anywhere from 50 to 60%, in fact, probably more than that in terms of LDL cholesterol reduction. And they've been shown to be safe and well tolerated in phase 2 and 3 studies. As I mentioned, PCSK9 inhibitors are humanized monoclonal antibodies. Just a few words on the pharmacodynamics and pharmacokinetics of these two medications. Alirocumab is marketed as Praluent and evolocumab is marketed as Repatha. Both are given as subcutaneous injections 2 weeks apart. Or in the case of evolocumab, it also comes with an on-body infusor, which you can give in a once in 4 weeks regimen. Both of them have to be stored in refrigerators, but you can maintain them at room temperature for a finite period of time. Nasopharyngitis seems to be the most common side effect. Their half-lives run anywhere from 2 to 3 weeks, and both of them are follow the hepatic elimination pathway, so there's no dosage adjustment in renal disease. Now, whenever we talk about LDL reduction, whenever we talk about anti-lipidemic therapy, there are 2 or 3 basic requirements that we look for as physician scientists before we incorporate the medication into our practice. First, obviously, we want the LDL to be reduced. If it is not a statin, then that medication, whatever it might be, has to reduce over and above that of a statin. It has to be synergistic to a statin, or if it is in place of a statin, then it has to reduce the LDL cholesterol over and above that which is offered by statin therapy. But also, the holy grail of antilipidemic therapy is really improving outcomes, improving major adverse cardiac events. And we do have now excellent outcome data with the PCSK9 inhibitors. And I will go over these two really landmark studies, the FOURIER trial for evolocumab and the ODYSSEY for alirocumab. And then the third and really a, a good function to have is, will this medication be able to reduce plaque? Yes, it's good to reduce LDL cholesterol. It is also great and obviously very essential to improve outcomes, but can the medication reduce plaque? And that's another thing that we will be talking about. So in terms of LDL reduction, what the PCSK9 inhibitors have shown is that they exert pretty much an unparalleled LDL reduction. They can, acting alone, lower the LDL up to 50%. And when combined with statins, that LDL lowering can be taken all the way to 70% reduction, which is amazing, hitherto really unheard of LDL levels. And in my own personal practice, I've seen LDLs of 14, 10, numbers that, I've never seen them previously in my life. So, and that's got to be something that is exciting. Statins obviously are the current backbone of anti-lipidemic therapy, as we all know. But when you add PCSK9 inhibitors, there's a significant effect in terms of not just LDL lowering, but reduced incidence of MI and fewer strokes. As I mentioned, the origin of this whole molecule and PCSK9 being identified as a potential therapeutic target was actually recognized by the gain of function mutation in a certain section of the population where there was a lot of premature atherosclerotic cardiovascular disease, especially the data from the Dallas Heart Study. That is how this whole concept came into being. And now we've come a long way in terms of really developing these medications. I'd like to go over the FOURIER and then the ODYSSEY trials because I think these are very important. These are really landmark trials, very well done trials. For example, the FOURIER had over 27,000 patients. That's a huge study. All of these, or most of these, were high-risk patients with established cardiovascular disease, either prior MI, stroke, or symptomatic PAD. And these patients were randomized into evolocumab or placebo plus statin. Evolocumab plus statin or placebo plus statin, and they were followed. It was a randomized double-blind trial. There was a significant reduction in LDL, on almost 60% mean reduction, with a mean LDL down to 30, with a variance between 19 to 46. So you can see that LDL levels were driven down to the teens, really. And as expected, the significantly reduced primary outcome of cardiovascular death, MI, stroke, revascularization, or hospitalization for unstable angina. Even the secondary outcomes of death, MI, stroke were also significantly reduced with evolocumab addition. Not only that, lower the LDL cholesterol, better the outcomes. LDL levels as low as 20 were associated with the best possible results in terms of the outcome reduction. So again, how low can you go? There's really no floor there. You could go as low as possible. Again, the same major adverse events were not very different. LDL cholesterol lowering proved to be far better than otherwise. You could go as low as you can possibly achieve. And then moving on to the ODYSSEY trial, which was outcome data from with alirocumab. The difference between FOURIER and ODYSSEY is that ODYSSEY now included patients with recent ACS, acute coronary syndromes, who are already on maximally tolerated statins. So patients with recent MIs, recent unstable angina, recent non-ST elevation MI were the ones that were included, randomized to alirocumab and placebo. And then again, a randomized double-blind placebo-controlled study, and patients were followed. Significant LDL reduction, up to 50 to 60% reduction in LDL levels, but more importantly, significantly fewer non-fatal MI. Death itself, cardiovascular death, or including death from unknown cause, was not significantly different, but the primary outcome data was driven by reduced non-fatal MI in the alirocumab arm. Again, safe, not much difference in adverse events. You will see that there seems to be more myalgia in the alirocumab patients. That probably is because of the statin that the patients were also on. Why the placebo arm had fewer myalgias is it's not readily explainable, because myalgias per se is not a well-known side effect of PCSK9 inhibitors, although there is nasopharyngitis and maybe some flu-like syndromes. Maybe the patients had perceived mild, flu-like syndromes as myalgia. It's difficult to say, but myalgia is not a described or a well-known side effect of these medications. Moving on to the GLAGOV study, this is the study that showed reduction in atherosclerosis. And this is a really exciting piece of information because, like I said, yes, it's important to reduce cholesterol. Yes, it's very important to improve cardiovascular outcomes with these medications. But for the first time, really, for the first time ever, a medication was shown to reduce the atheroma burden, what we call the percent atheroma volume. And so far, statins were barely shown to stabilize the plaque. They were never shown to reduce the plaque. But now, for the first time, we had managed to reduce plaque, and in a pretty big way with PCSK9 inhibitors. So GLAGOV study randomized evolocumab statin combination versus placebo statin in patients with non-obstructive CAD, and these patients were followed with serial IVUS studies, intravascular ultrasound. So everybody had serial intravascular ultrasound studies. Yes, obviously, evolocumab greatly reduced LDL, but if you see the percent atheroma volume that you can calculate with an IVUS, there was about a 0.05% increase actually in the statin arm, which is not a significant increase. You would probably say the plaque was stable, but there was an almost 1% decrease in the atheroma volume in the PCSK9 arm, which is a significant, piece of information. There's almost 64% of people in the evolocumab arm showed some sort of plaque regression. And also, regression was more likely when LDL was less than 60. So hitherto, and this kind of changes some of the things. This really changes the way we practice, because up until this point, we were always thinking about a target LDL less than 70. If somebody had an LDL of 70 or 65 after an MI, that was okay for most of us. But now, again, I go back to that, how low can you go? There's really no floor. If you can manage to get the LDL less than 60 through safe and effective means by like this, then you have made a positive impact on regression of the atherosclerotic plaque. So the main indications for PCSK9 inhibitor therapy, obviously, number one, statin intolerance. If your patient is intolerant to statins, then now there's a great new and effective alternative. Patients with familial hypercholesterolemia who really did not have many choices prior to now can now be placed on PCSK9 inhibitors and have significant reduction in their LDL and see lesser event rates. And then in the third, probably one of the most common indications for PCSK9 inhibitor therapy is failure to achieve target LDL in the setting of known atherosclerotic cardiovascular disease, despite being on a maximally tolerated statin. And this is the indication where there's a lot more work to be done, a lot more room to really give patients the benefit of these medications to positively impact their LDL and their lives. And there are obviously limitations. These are subcutaneous injections. They're not pills, although the subcutaneous injections are anywhere from once in 2 weeks to once in a month. Patients are apprehensive. I do have one or two patients here and there who are apprehensive about injections. They may already be on insulin subcutaneous injections, and although this is not a daily injection like an insulin, they still are apprehensive about an extra subcutaneous injection. It seems to be, far easier to pop in a pill than to inject yourself. In fact, I have a patient who is on one of these medications, but he has his wife do the injection while he's sleeping, because he just does not want to know that he's getting a subcutaneous injection. It's just, an apprehension that we have to understand and appreciate and guide them through that process. Cost, obviously, a huge obstacle. As you can see, the annual average cost of statin therapy is about $186, but PCSK9 inhibitors almost $15,000 for the whole year, which is a significantly increased cost burden on the healthcare system. And this day and age, that's a very important thing to look at. And one of the things that I always not only ask myself, not only I use that to kind of educate patients, but also ask of the industry to come up with data that can, give us a little more information. Like, for example, what I'm trying to look for is, Yes, PCSK9 inhibitors cost this much more, but what if you factored in the extra number of lives saved? What if you factored in the extra number of MIs that are saved over and above that of statins? Uh, are they going to be still considered to be costly if you factored that in? I think not. But I'm yet to see compelling data in that regard. But I always ask industry to come up with those kind of numbers, and I hope they do. Sooner than later. And in the end, a few take-home points. Number one, you want your LDL lowered as much as possible, as low as possible. And if you cannot take a statin, or if you're on a statin and you still cannot get your LDL levels as low as they should be, then please consider PCSK9 inhibitor therapy, because these medications are not only super effective in reducing LDL cholesterol, they've also been shown to improve cardiovascular outcomes. With that, I would like to thank everyone and have a good day, and I hope the rest of 2020 is better than what it was up until now. Thank you.